let me just take a look at some more indexes here, because we just mentioned a few, but there's more. There's the Systemic Lupus Erythematosus Disease Activity Index, a SLEDI, the Safety of Estrogen and Lupus Erythematosus National Assessment, the SELENA-SLEDI, the British Isles Lupus, I can go on, Assessment Group Scale, the BILAG, the Systemic Lupus Activity Measure, the SLAM, the Systemic Lupus International Cooperating Clinic /ACR SLIC /ACR Damage Index, and I'm running out of breath. Do these metrics help utilization decisions, or are they research tools?
Well, I'm going to chime in here to say that these are research tools, and no one ever said that it was going to be easy to measure outcomes in lupus, because you're dealing with multiple organ systems, and within each organ system the disease might be mild, moderate, or severe, and it's going to change from visit to visit, and it will change every time treatment is changed. So for our randomized clinical trials, we actually don't even use just one of those instruments. We usually use a combination of 3 of them. Until we have better biomarkers, this is the best we can do right now to measure outcomes in lupus. But it's daunting, and I don't want the clinician in practice to have to learn these instruments. And I also don't want managed care to make a decision on who's going to get a new biologic based on these instruments, because they are flawed.
All right, so who makes the initial diagnosis? Where are patients with SLE most frequently diagnosed?
Well, we talked about the fact they may be misdiagnosed in a primary care practice that's still depending on the ANA. I think patients will present based on their initial symptomatology. Skin rash might go to a dermatologist. Arthritis might first go to their primary care doctor, but eventually they tend to be triaged either to rheumatology, or if there's renal disease, often to a nephrologist. I think by the time the person gets triaged to that specialty level, the correct diagnosis is made.
And are there gaps in care along the way? And what do we need to do to close those gaps if they're there?
There can often be gaps, especially with the lupus rashes. Often by the time I see a patient with the discoid rash, which is the most disfiguring one, the patient already has permanently lost her hair. She already has hypo or hyperpigmentation of the face or forearms, which will disfigure her for her entire life. So yes, more rapid referral to dermatology or academic rheumatology practices, I think, is still an important need.
So let me turn to you again. We have all of these scales, which she just tells us are research tools, not necessarily the greatest thing for predicting outcomes, not really good for reimbursement. Are there practice guidelines that you have that you use for lupus, or are you just winging it?
We tend to use national guidelines, but
what are those?
The challenge tends to be where if a drug was studied and the clinical outcomes used in the trial were endpoints that we're mentioning here. In the real world, then we want to know, because the drug's expensive, we want to know, is it working or not working? And it becomes a challenge for us to have that dialogue around, because these tools aren't practical in the real world to be able to use. The drug is costly. What's the definition of success looks like? We don't have one. And that there lies the
And we're going to
challenge.
face this, of course, with Benlysta, belimumab,
Yes.
which was the first biologic approved for lupus, because it is very expensive. And because the clinical trials of Benlysta in the United States, what was called the Bliss 76 trial, only showed a 10% difference in the outcome measurement between the Benlysta group and the standard of care group. So that doesn't sound like a big difference.
It does to me. 10% is a lot.
Well, especially when you have to understand the flaws in the instruments and the fact that the instruments for the Benlysta trials required that an organ manifestation resolve. So they didn't ask for a partial improvement. It had to resolve.
All right,
But given all of that, we still have to individualize it. Post-hoc analyses can help, and especially in Europe, the EMA is limiting Benlysta use to patients that have low complement and anti-DNA, because that does describe a subset that does particularly well. But I think in the United States, we don't want to then limit its use, because patients who didn't have low complement or anti-DNA could also be responders.